Reading the chest radiograph. An overview of the radiograph, you can see about the principles of evaluating radiograph. Densities of structures determine the opacity. High density structures appears white. Bone, this appears white. Soft tissues is light gray, water is gray, fat is dark gray, and air is black. For the systemic review of structures, ABCD style in reading the radiograph. A denotes for the abdomen. Check the gastric bubble or the pneumoperitoneum if taken upright. B. Bones. Check for fracture. C is chest. Check for the heart, great vessels and lungs. D is devices. Check for the devices, endotracheal or a gastric chest tube. Stand-up projections. PA upright. Performed on the older patient's teenage years. Not advisable for the younger patient due to their attention span. Looking away from the camera and everyone else can make for a very agitated child. AP upright. Ideal for the cooperative children. AP supine. Ideal for the uncooperative younger children due to the ease of positioning. AP supine neonatal performed mobile in the neonate unit. Lateral. To highlight the pathology in mediastinum, claustrophrenic recess, and localize the lesion. Requested to further access and clarify the lesions seen on the front X-ray views. Left lateral view. Preferred position as it provides a better anatomic detail of the heart. Lateral distributors. This is a special projection used to demonstrate the pleural effusion and the pneumothorax. For pleural effusion, the site of interest should be down. For pneumothorax or the pneumoperitoneum, the site of interest should be up. Basic steps in reading the chest or the babygram radiograph. Step 1 is to identify the general data of a patient. Step 2, determine the view, PA, AP, lateral and distributors. Step 3, assess the quality of film. Step 4, assess the anatomy. Step 5, determine the presence of the abnormalities. Identifying the general data of the patient. Patient's name and age, date and time chest X-ray was taken. Second step, determine the view, anterior posterior view and the posterior anterior view. If the patient is supine, no winging of scapula. Heart and other structures are more magnified. Usually for infants, young children and very ill patients who cannot stand. Straight ribs, vertebral bodies are rectangular. For the posterior anterior view, the patient is upright, winging of scapula. Heart is not magnified. Usually for older children and adolescents, angulated ribs, Mongolian hat sign may be appreciated. Clavicle is more horizontal in the AP view, V-shaped clavicle. Assess the quality of the film. Visualization. Good visualization is characterized by the inclusion of the entire thoracic cage, lung apices and first ribs caudally, edge of ribs laterally. Reported as good visualization. Inspiratory effort. Chest X-ray are conventionally taken while patients are in the inspiratory phase of the respiratory cycle. One should count 6 to 8 anterior ribs, 9 to 11 posterior ribs. Diaphragm should be intersected by the 6th rib in the mid-clavicular line. Inadequate inspiration leads to crowding of the structure. Reported as a good inspiratory effort, of no value in the infants. Exposure or the penetration. This pertains to the degree in which the X-rays are passed through the body. A well-penetrated or exposed chest X-ray is one where the upper 4 thoracic vertebrae and the vertebrae behind the heart are just visible. Reported as good exposure or the penetration. Figure on the left displays a overexposed film. Greater than T4 are exposed. In the figure on the right, displays are underexposed since the lesser T4 are exposed. Obliquity or the rotation. The spinous process should be in the midline and should be equidistant from the medial ends of the clavicle. Rotation may lead to the misinterpretation of the structure. Reported as a no obliquity or the significant rotation. Presence of artifacts. The artifacts may be due to the radiographic techniques, patient factors, and non-anatomical objects. Let us see about the axis of the anatomy. Normal lungs and the pleura. The left lung is divided into two lobes, left upper lobe and left lower lobe. Dividing the two parts is the oblique fissure. The right lung is separated into three lobes, right upper lobe, right middle lobe, and the right lower lobe. The lateral chest X-ray is useful in delineating the features pleura. This is located in the interface between the lung zones and the ribs. Normal body structure. The bony structures are the densest and the most radiopaque, whitest structure seen on the normal CXR. The bones visible on the CXR are the clavicle, rib, scapula, parts of spine, and the proximal humerus. The bony structures are often used references by which the obliquity, adequacy of the inspiration, and exposure are assessed. Normal heart and vessels. The vascular marking. The normal vascular markings are more prominent in the lower lung zones, shows a gradual tapering towards the periphery of the lungs and are usually symmetric. Normal mediastinum. The mediastinum contains the heart, great vessel, middle mediastinum, and the potential space anterior to the heart and the posterior to the heart and above the heart. Thymus increases in size from birth to puberty, but as a child grows, the thymus appears smaller. Cardiothoracic ratio of the heart. Size of heart is assessed by the CTR. Increased CTR suggests the cardiomegaly. Calculated by getting the ratio between the cardiac size and the thoracic width. Cardiac size is measured by drawing the vertical parallel line down the most lateral points on each side of the heart and measuring between them. Thoracic width is measured by the vertical parallel line down the inner aspect of the widest points of the rib cage, measuring between them above the diaphragm. Normal CTR measured in the PA wave. Since AP wave causes a magnification of the heart size, the normal pediatric CTR varies. Cardiac chambers and the great vessel. See the illustration above the overview of anatomy in the chest radiograph. The left heart border corresponds to the lateral border of the left ventricle. Right heart border, lateral border of the right atrium. Upper zone vessels are normally smaller than the lower zone vessels. Other structures like airways. Trachea is at the center, slightly to the right, as an area of radiolucency. It eventually branches at the carina into the two main bronchi. Hilar structure. Lung roots at the hilar are occupied by the major bronchi and the pulmonary vessels. The left hilum is often higher than the right. Both should be similar density and the overall size. Costophrenic angles created by the dome of each hemidiaphragm on the lateral chest walls. On the frontal chest extreme, costophrenic angles should form sharp acute angles. Hemidiaphragm, well defined dome shaped structure occupying the caudal end of the phylum. Right hemidiaphragm is slightly higher than the left because of the lever below it pushes cranially. Below the left hemidiaphragm, a round area of recency is occasionally found. Gastric bubble. Determine the presence of abnormalities. Lungs. Increased density in the lung zones appear as area which are whiter than the surrounding structure. Area may be filled with exudates, transudates, blood and the malignant cells. Decreased density in the lung area. Area in appear which are darker than the surrounding structure may be filled with air. Displacement of the lung fissure. Volume changes within the certain lung lobe or zone may lead to the pushing or pulling of fissure. Lung hyperexpansion. Greater than 10 posterior ribs visualized in the lung parenchyma. Pleural thickening seen in the asbestosis mesothelioma. Prominence of the pleural space. Air may be trapped in the pleural space, pneumothorax. Mediastinum and the vessels. Increased vascularity. Uniformly enlarged vessels at the cilia and within the lungs. Main pulmonary artery is enlarged, greater than the diameter of the trachea, and forms a convex bulge. Vessels are seen even in the periphery. Loss of tapering. Decreased vascularity. Uniformly small pulmonary vessels. Mediastinal widening may be due to the technical factors, that is improper patient positioning, suboptimal inspiration, rotation, or the presence of masses or the vessel widening. Heart. Left ventricular enlargement. Apex displaced inferiorly and laterally, drooping apex. Right ventricular enlargement. Apex displaced superiorly and laterally, uplifted apex. Left atrial enlargement. Prominence of the left atrial appendage. Loss of cardiac waistline. Widening of the carinal angle greater than 70 degree. Double density sign on the right cardiac border. Right arterial enlargement. Bulging the right heart border. Height is greater than 1 by 2 of the right cardiac cylinders and 1 by 3 of the right hemithorax. Tracheal displacement. Anything that increases the volume or pressure in the one hemithorax will push the trachea and the mediastinum towards the contralateral side. If it appears this causes the volume loss, it will push the trachea towards the ipsilateral side. Diaphragmatic abnormalities. Obscured hemidiaphragm may be due to the adjacent lung disease. Displaced may be due to air, viscous underneath, phrenic nerve palsy or the hernia. Common pathologies and the chest radiograph findings. Pneumonia. Left lower lobe pneumonia showing the opacification in the lung field. Consolidation. Inhomogeneous opacities with a prominent air bronchogram. Pulmonary edema. Prominent hilar vessels in the bad vac distribution and the cephalization of the vessels. Thickened subpleural interlobular septae at the lung periphery, Kerley B lines. Pulmonary tuberculosis. Hilar nodularities in the primary infection. Gone focus. Opacities in the upper lung fields and the cavitation. Atelectasis, collapsed lung, opacification of the lung fields usually in the triangular shape, elevation of the diaphragm, narrowing of the rib interspaces, hyaline membrane disease, pronounced pulmonary under aeration, fine granular ground glass opacities in the both lung parenchyma, periphery extending air bronchogram. Pneumothorax, lung collapse due to the air in the pleural space, absence of the lung markings. Pleural effusion, blunting of the costophrenic sulci, meniscus kind. In massive effusion, there may be the shifting of the mediastinal structure to the contralateral side. Pneumoperitoneum, presence of gas underneath the diaphragm. In this image, the darker beneath the hemidiaphragm correspond to the air occupying that compartment. Pericardial effusion, generalized enlargement of the cardiac shadow, water bottle sign, with a normal vascular marking. Foreign body. Coin in the esophagus. Discoid metallic density. Coin in the posterior tracheal region. Coin is flat on the lateral view. Congenital diaphragmatic hernia. Presence of bowel lobes in the hemithorax. Mediastinum is shifted contralaterally. Abdomen is devoid of gas.